Okay, let's pray first. Huwag na natin hintayin yung iba. Ang mahalaga nandito na kayo. Okay. To the Father, the Son, and the Holy Spirit.
Little boy of 13 is way to school. He heard a crowd of people laughing and he went to take a look. Thousands were listening to the stories of one man. He spoke with such wisdom, even the kids could understand. The hours passed so quickly, the day turned into night. Everyone was hungry, but there was no food in sight. The boy looked in his lunchbox at the little that he had. He wasn't sure what good it do. There were thousands to be fed, but he saw the twinkling eyes of Jesus, the kindness in his smile, and the boy cried out with the trust of a child. Take my 5 loaves and 2 fishes, do with it as you will. I surrender. Take my fears, my inhibitions, all my burdens, my ambitions. You can use it all to feed them all. I often think about that boy when I'm feeling small, and I worry that the work I do means nothing at all. But every single tear I cry is a diamond in his hand. Every door that slams in my face, I will offer up in prayer. So I'll give you every breath that I have. Oh, Lord, you can work miracles. All you need is my amen. So take my 5 loaves and 2 fishes, do with it as you will. I surrender. Take my fears, my inhibitions, all my burdens, my ambitions. You can use it all. Hope it's not too small. I trust in you. I trust in you. So take my 5 loaves and 2 fishes, do with it as you will. I surrender. Take my fears, my inhibitions, all my burdens, my ambitions. You can use it all. Oh, yes, it's too small.
Alright, good morning guys. Okay, pakita muna. ng mga magaganda at mga poging mga faces. Yan. Dami ng online. Okay. Yan. Okay, happy Sunday to all. Makakapagsimba pa kayo later, no? Okay, this afternoon. Kasi hopefully we can finish the discussion at 2 p.m. Yan. Okay. Alright. Medyo content. Medyo marami-rami na rin pala. 21, no? Okay, plus 15. Ang kala Doc Jebet, no? And Doc Lori. Okay. Oh, si Alex, nakalaan na, Doc Lori na. Nasa hospital kayo?
Yes po.
Okay. Ilang po ba? Doc Lori, ilang bed capacity kayo?
$500. 600.
600?
Actually, 300 lang, pero 600 lang. In papers, ang function.
Ang laki Nice.
100 in capacity, but only in papers, 300.
Pero na-inspect na doc ng ng DOH?
Government hospital eh.
Hindi pa nabigyan ng LTO?
Hindi pa as of now.
Okay.
Kulang pa ng infrastructures.
Okay. Kailan ang target date nyo to open?
We're open, kaya lang before the pandemic, mga 600 ang na-occupy ng hospital. At present, medyo nagbawas because of the pandemic.
Okay. Nagbawas pa po kayo Ngayon samantalang yung iba okay, they are opening beds for the cases of COVID. Marami na rin po ba dyan?
As of now, konti lang. Ang problema kasi, yung manpower, yung mga nurses, kulang because they are accommodating the COVID patients. They go 2 weeks straight and then 2 weeks off.
Okay. Apply ako dyan, Doc. Para
Good.
Nakasawa na sa office Anyway. Okay. So good morning again. Okay, we will be starting in a minute. Okay, may hinintay lang tayo na konti. Okay. Our topic for today, hanggang sa matapos tayo later, would be the algorithm. Okay, that will be our first topic for today, the algorithms. Okay, this is where we use our electrical therapy and pharmacological therapy. Okay, we will follow the algorithms. Okay. Specifically the bradycardia algorithms, the tachycardia algorithm, the cardiac arrest algorithm, and the return of spontaneous or ROSC algorithm. Okay. Then after that, we will continue the discussion with the 12-lead ECG, the acute coronary syndrome. Okay. The stroke. Okay. The stroke is the shortest, and lastly, the basic and advanced airway management. Okay. All right. I would like to remind you guys that your hospital policy is the most important. Okay, these are just the recommendation of International Liaison Committee on Resuscitation. So if ever you have the different protocols or the processes of the emergency care in your hospital, that must be what you have to follow, hindi yung sa recommendation. But these recommendations will serve as, your guide. Okay? All right. Now, let's start. Yeah. Okay. Yeah. Okay. We have we have 7 algorithms. Okay. Additional algorithms that we have, okay, are the ACS and stroke algorithms. Okay. Yeah. Okay, so we will start with the bradycardia with pulse algorithm. Okay. Okay, let's have a short review, okay, of the discussion yesterday, okay, about the pharmacological therapy and the electrical therapy. Okay, I mentioned yesterday that we have three, okay, major therapy, okay, in our advanced cardiac life support. Okay, we have the mechanical therapy, okay, which is the use of the cardiopulmonary resuscitation, both in BLS and ACLS. Okay, we have the electrical therapy, okay, the use of defibrillation and the cardioversion, and the pharmacological therapy, okay, specifically the anti-dystonia medications used for the narrow QRS, no? Tachydysrhythmias, okay, both narrow and wide pala, no? Regular and irregular. All right. Now, let's have a scenario, okay, first, okay, before we discuss, okay, the bradycardia and the tachycardia algorithm. Okay, the scenario should always be in the hospital, okay, for the bradycardia and tachycardia. Okay, all right. The first box, the second box, and the third box of the bradycardia, okay, and the tachycardia here, yeah, okay, as you can notice, okay, they are the same, okay. First, second, and the third boxes. Okay, yeah, okay. The first box is assess the appropriateness for the clinical condition. Okay, all right. This is where we have to assess, okay, the secondary, okay, survey, okay, to the patient. Okay, all right. The primary assessment is what we do, no, in the basic life support. Okay, we have to assess for the responsiveness, okay, the breathing, and the pulse. Okay, while in the secondary assessment or the secondary survey, all we need to do is to get the vital signs of the patient, and from the vital signs, okay, we will move to the second box, okay, which is the priority, okay, or the uh, facilitation, okay, of whatever we can do, no, okay, based on what we've assessed in the secondary survey. Okay, let's say for example, okay, the patient rush, no, in the emergency department, okay, with the complaint of lightheadedness, no? Okay, and chest discomfort. Okay, all right. Okay, any chest discomfort, okay, especially if the patient is greater than 40 years old, okay, we have to get the, or we have to attach the patient in a cardiac monitor to assess the rhythm of the heart. Okay, all right. Okay, let's say, okay, we've already assessed, okay, the vital signs. Okay, there is a complaint, okay, of difficulty of breathing. Okay, the oxygen saturation is 93%. Okay, the blood pressure is 180, no, okay, over 50. Okay, and there is a complaint of chest discomfort. Okay, all right. So in the second box, okay, we have to identify and treat underlying cause. Okay, if we have to maintain the patent airway, and since the patient, okay, is complaining of the difficulty of breathing, we have to assess the breathing, not as necessary. Okay, we have to give the oxygen therapy, okay, as indicate or if needed. And since the oxygen saturation is just 93%, okay, we have to do we have to give the oxygen therapy. Okay, attach the patient to the cardiac monitor. Okay, monitor the blood pressure, okay, and the oximetry, IV access for the emergency medication, and the 12-lead ECG. Okay, all right. Let's say, for example, okay, we've analyzed, okay, the rhythm of the patient, okay, which is the sinus bradycardia. No? It's not enough, okay, that we diagnose sinus bradycardia. Okay, we have to take the 12-lead ECG. Okay, baka mamaya merong acute coronary syndrome, and then from that case, okay, we have to follow, okay, the acute coronary syndrome algorithm. Okay, all right. On the third box, okay, this is the determination of the status of the patient. Okay, all right. It will branch out, okay, to two. Okay, the yes, no answer, and the no answer. Okay, this is a question. Okay, persistent bradyarrhythmia, okay, causing hypotension. Okay, all right, acute altered mental status, signs of shock, skinny chest discomfort, and acute heart failure. Now, any of these, okay, if ever, no, okay, any of this is present, no, okay, from our patient, okay, we have to answer. Okay, it's either yes or no. No? Okay, if there is no signs, okay, of the third box, no, any of the third box, okay, we just have to monitor and observe the patient. Okay, right. This is called the asymptomatic, no, okay, bradycardia. Okay, but if the answer is yes, okay, or kahit isa lang, no, let's say for example, we have the 80/50 blood pressure, that is hypotension. Okay, we have to treat, okay, the patient. Okay, all right. If the answer is no, okay, the patient is still stable. No, if the answer is yes, the patient is now unstable. Okay, and the first line of treatment, as we've discussed yesterday, okay, for the pharmacological therapy is the atropine sulfate. Okay, 0.5 milligram, no, IV bolus, okay, every 3 to 5 minutes for the maximum dose of 3 milligrams. Okay, all right. If ever we consume, okay, all the dose, no, okay, of the atropine, okay, we can have the dopamine and the epinephrine, okay, as our second line of treatment. Okay, but in sinus in bradyarrhythmias, okay, we can also consider the transcutaneous pacing. However, excuse me. However, okay, this is for the expert consultation. Okay, the cardiology thing. No? Okay, in transcutaneous pacing, okay, we have to use a machine. Okay, and it is usually included, no, in the electrical therapy or in the defibrillator machine. Okay, if your defibrillator machine is capable of transcutaneous pacing, then we can start, okay, the pacing, okay, of the patient. Okay, all right, that is for the Brady arrhythmia. Okay, now let's say for example, okay, the case of the patient is for example, is rushed into the hospital with the complaint of palpitation. Okay, wala na tayong ibang maisip doon, okay, if the complaint is palpitation, okay, baka okay, the case of the patient is tachydystrhythmia. Okay, so again, okay, we have to assess the patient. Okay, we have to identify and treat the underlying cause, and get on the third box, get the status of the patient, now whether stable or unstable. Now, if the answer is yes, okay, the patient is already unstable, okay, the management is synchronized cardioversion. Okay, if the answer is no, okay, then the patient is still stable. All right, okay, the management is below. Those are the anti-dysrhythmia medication. Okay, all right. So we've already discussed, okay, the medications. Okay, for a review, okay, again, adenosine, okay, is for narrow QRS regular tachycardia, that is the SVT. Okay, 6 milligram rapid IV push followed with 10 or 20 cc, no, okay, plain NSS flushing. Okay, then after 2 minutes, we have to reassess the patient. If the patient is still stable, we will give the second dose, which is the 12 milligram. Okay, hanggang doon lang yun, hanggang second dose lang. All right. Okay, amiodarone, case for a white QRS, regular tachycardia. This is the most common medication that we give in white QRS kasi wala tayong procainamide, no, here in the Philippines. Okay, all right. Again, okay, for the unstable patient, okay, synchronized cardioversion, okay, you have to know, okay, the different energy level, okay, for the different dysrhythmias. Okay, for the review, okay, for the SVT, we have the 50 to 100 joules, synchronized cardioversion. Okay, for atrial flutter, okay, we have 50 to 100 joules. For atrial fibrillation, okay, we have 120 to 200 joules. And for monomorphic ventricular tachycardia, we have 100 joules. Okay, all right. Again, okay, for the unstable polymorphic ventricular tachycardia, okay, both with or without pulse, okay, we have to give defibrillation, not cardioversion anymore. Okay, all right. Okay, so the bottom line is we need to obtain, okay, the status of the patient. If the status is still stable, we give pharmacological therapy. Okay, if unstable, we give the synchronized cardioversion, but only, okay, in tachycardia, no, in tachydysrhythmias. Okay, we do not give cardioversion or electrical therapy, or I mean cardioversion or defibrillation in bradycardia. Okay, all right. Now, let us suppose, okay, despite of the management, okay, that we give to the patient, okay, the patient, okay, becomes unconscious. Okay, then when we check for the pulse, okay, and breathing, okay, there is no pulse and there's no breathing. Okay, that is the time, okay, that we should follow the cardiac arrest algorithm. Okay, kasi cardiac arrest na yung patient. Okay, now, okay, after After the reassessment of the patient, okay, and we've assessed that the patient is in cardiac arrest, okay, we have to activate, okay, the code blue, okay, in the hospital or any emergency response, okay, in your hospital. Okay, then go back to the patient and start CPR. All right. Okay. Wala kang ibang gagawin, okay, kundi perform the CPR and wait for the code blue team, okay, to arrive. No? Okay. All right. And these are we have 6 team members, no, a basic and standard team members. Okay, we have the team leader. Okay, and most of the time, okay, the team leader is the doctor. Okay, or okay, it is the charge, okay, of the charge nurse, the head nurse, okay, of the department. Okay, they work, no, hand in hand, okay, with the doctor. We have the compressor, okay, as you know, okay, initiated the CPR. Okay, the ventilation, okay, they're responsible for the bag mask ventilation. Okay, the medicationers, okay, they're responsible for obtaining the IV access. The electrical therapy, no, okay, or the machine or the defibrillator operator, and the documentation, okay, or the scribe. Okay, the moment that the team members, okay, or the team, okay, arrive, okay, there should be distribution, okay, of the role assignment, okay, right? There should be someone, okay, who should initiate, okay, the ventilation. Okay, someone should attach the patient to the cardiac monitor, okay, and someone should obtain, okay, the IV line, okay, as fast, no, as he can, right? Then the moment, okay, that we have the rhythm now in the cardiac monitor, we have to stop, okay, the CPR in order for us to analyze the rhythm. Okay, so in this step, okay, we have to determine, okay, if the rhythm is shockable or non-shockable. Again, okay, for the non-shockable rhythms, we only have asystole and PA, and for the shockable rhythm, we have the ventricular fibrillation and the ventricular tachycardia. Right? Okay, so the same, okay, ang process nila. Okay, we will have the CPR every 2 minutes. Okay. But in shockable rhythm, okay, we have to shock the patient, no, every time or every after, okay, we assess that there is a shockable rhythm, okay, all right, and that is the only difference, okay, for this right side, okay, all right. Now let's suppose, okay, that we analyze a shockable rhythm, let's say a ventricular tachycardia, okay. All right. Every time we have a ventricular tachycardia, we should always check for the pulse, no? Okay, baka kasi mamaya meron na siyang pulse, no? Okay, but let's suppose, okay, that the ventricular tachycardia, okay, has no pulse. So this is a pulse ventricular tachycardia, and the only treatment, okay, that we should prioritize this time, okay, is the shock. Okay, all right. So the team leader, okay, will order, okay, let's defibrillate the patient, okay. 120 to 200 joules is our initial energy level. Okay, so the while the machine is being prepared, okay, for the shock, okay, the CPR, okay, must continue. Okay, all right. So the operator of the machine, okay, will set the machine. Okay, all right. He or she will clear, okay, the surroundings. Okay, saying clear the patient. Okay, so if once the machine is already charged, okay, the machine operator, okay, should clear, okay, the surroundings for the second time. I'm clear, saying I'm clear. Are you clear? So everybody's clear. I'm shocking on 3. On the 3rd count, okay, he should push the shock button. Okay, right after the delivery of the first shock, okay, we have to perform, okay, the CPR again. Okay, as you can see here, the step number 4, okay, you have to perform the CPR for 2 minutes. Now, okay, the 5 cycles of CPR, okay, the 30:2, okay, CPR, okay, is equivalent to 2 minutes. Okay, kaya meron diyang 2 minutes. Na? But, na, okay, if in case, let's say, for example, the patient is already in the hospital, or let's say the patient is already in the intensive care unit with a tube, okay, the 2 minutes, okay, should be timed by the documentation nurse. Okay, all right. Take note of the difference. Huh? Okay, if the patient, okay, has no advanced airway, okay, there should be still, no, a collaboration, okay, of the the compression and the rescue breathing. Okay, we will follow the 30:2, but if the patient already has, okay, the advanced airway, okay, the CPR or the compression, okay, should be continuous, okay, for 2 minutes, okay, while, okay, the ventilation, okay, through bag to tube, okay, is continuous, okay, every 6 seconds, no? Okay, every 6 seconds na yung ventilation natin, okay? All right, now, but in this case, let us suppose na kakarating lang ng patient na nasa ER, okay, wala tayong tube. Okay, all right. So we have to perform, okay, the 30:2, no, CPR. Okay, and as much as possible, okay, someone, okay, should access, okay, the IV line. All right. Then after the 5 cycles, okay, we have to recheck again for the pulse and check for the rhythm. Okay, if the rhythm, okay, let's say for example, is still shockable, okay, we will continue, okay, to shock the patient. Right. Right after the second shock, okay, we have to perform again, okay, the CPR, okay, paulit-ulit lang yung process yun. Okay, but this time, okay, we have to give the epinephrine, okay, all right, and when the team leader orders, please give epinephrine, okay, every 3 to 5 minutes, kahit hindi na niya yun ulitin, no, okay, on the next 3 to 5 minutes, okay, the medication nurse and the documentation nurse should be the responsible, okay, role assignment, okay, to monitor, okay, the next dose of epinephrine. All right. Okay. Now, the epinephrine, okay, is recommended or advisable to give after the second shock. Okay, if we are in the shockable rhythm scenario. But here, okay, if we do not have a shockable rhythm, the moment, okay, that we have the IV access already, okay, we have to give the epinephrine. Okay. As long as na meron na tayong line, okay, you have to give the epinephrine, okay? All right. Now, there is a bullet here, okay, saying consider advanced airway, okay? All right. Actually, okay, the advanced airway, okay, can be initially tried, not anytime, okay? All right, as long as that the CPR is not compromised. Let's say, for example, okay, in cardiac arrest kasi, okay, we are prioritizing the circulation. Okay, so we are prioritizing the compression. Okay, not the airway and the breathing. Okay, so when you try, okay, to insert, okay, the advanced airway, okay, you should not compromise, okay, the compression. Hindi mo dapat yun papahintuin. Okay, all right. If you are or if you will be having difficulty, no, inserting the advanced airway while there is someone, okay, doing the compression, okay, you can delay, okay, the advanced airway management, okay, and when is the recommended time, okay, for the advanced airway insertion, okay, right after the return of spontaneous circulation, okay, which is not happening here in the Philippines kasi mas inuuna nila, no, yung advanced airway, no, compared to compression, okay, all right. Now, let us suppose hindi natin na-insert, no? Okay, wala pa tayong advanced airway. Okay, after the 5 cycles, again, okay, we have to stop the compression and assess again, okay, for the pulse and the rhythm. If it's still shockable, we have to deliver the shock. Okay, all right. And this time, okay, if we already gave the third shock, it is considered to be a refractory, not shockable rhythm. Okay, all right. Ibig sabihin nun, okay, we have to give not medication, okay, for indicated for the refractory shockable rhythm, which is the amiodarone. Okay, again, the dosage of amiodarone, okay, for refractory shockable rhythm is 300 milligram IV bolus. Okay, not 150 milligram. Okay, all right. Then after the 2 minutes again, okay, follow the broken arrow. Okay, in between 4 to 5, okay, we have to check again, okay, for the pulse and the rhythm. Okay, all right. Now, let us suppose, okay, that this is not in this time, okay, this is the rhythm that we analyze is not shockable anymore. Okay, let's say for example, okay, we have the normal sinus rhythm. Okay, then we check for the pulse, no, right? So we follow the number 12 boxes. Okay, All right, so dalawa, no? Okay, we have two division here, no? Okay, once you check for the pulse, let's say for example again, okay, we have already obtained a normal sinus rhythm. Okay, then we check for the pulse. Okay, if there's no pulse, then this is PEA. Okay, no signs of return of spontaneous circulation. So we go to 10 or 11, and we will repeat again the process. Okay, all right, minus the shock. Okay, but if there is already a return of spontaneous circulation, okay, with pulse now, okay, we will no longer follow, okay, the cardiac arrest algorithm anymore, but we will go to the post-cardiac arrest care. Okay, all right. So in post-cardiac arrest care, okay, since we already have the circulation, okay, we have to prioritize the airway and breathing now. Okay, now we have to optimize ventilation and oxygenation. Okay, this time, okay, post-cardiac arrest, okay, we have to insert, okay, the endotracheal tube, okay, or advanced airway, okay, and maintain the oxygen saturation of normal. While there is someone, okay, doing the intubation, okay, there should be someone checking for the blood pressure. Okay, then if there is hypotension, we will treat the hypotension through by vasopressor infusion. Okay, we have the dopamine, okay, or the norepinephrine. Okay, all right. Now, let's say, okay, we've already inserted the advanced airway, and we are treating now, okay, the hypotension. By the way, guys, no, okay, in other facilities, okay, they treat the hypotension with IV bolus, okay, IV bolus first, okay, before the administration of the vasopressor. Okay, all right, we have a total of 1 to 2 liters, okay, for the IV fluid resuscitation for the hypotension. Okay, right. Now, okay, we have to obtain, okay, if the patient can follow command. Okay, you can whisper. Okay, bulungan natin yung patient, no, if he or she can squeeze, okay, your hand, okay, or can raise the hand. Okay, now if the patient cannot, no, okay, raise or cannot follow the command, okay, we induce the hypothermia. No? I will show you a video later on. Okay, it includes the short discussion of the induced hypothermia. Okay, so anyhow, okay, if the patient can or cannot follow command, okay, we will follow this box. Okay, this box, cardiac catheterization laboratory, is not constant here. No, okay, it can be changed. Okay, if we determine, no, okay, the reversible causes of cardiac arrest. Okay, these are the standard 5H and 5Ps. Okay, the reversible cause of cardiac arrest. Okay, all right, let's say for example we've checked the ECG, okay, and we've noticed or we've observed, okay, a STEMI, okay, or a thrombosis of the coronary, then this is applicable ng cardiac catheterization laboratory. But if there is other, no, causes, okay, of the reversible cause of the cardiac arrest, okay, then this will be changed. Okay, all right, or okay, we can monitor the patient to the advanced critical care, okay, or intensive care unit. Okay, all right, that is the 4 major algorithms. Okay, all right, now, okay, for us to fully understand, okay, or apply, okay, the algorithms on or how we take this, no, in action. Okay, there is a video, okay, from American Heart Association that this is a mega code. Okay, this is the best example, okay, of mega code, no, okay, in the hospital setting. It is a 20-minute video. Okay, for our reference, okay, on how to do, okay, the process, okay, of the resuscitation. Yeah.
Team dynamics are critical during a resuscitation attempt. The interaction among team members has a profound impact on the effectiveness of each individual as well as the patient's overall survival. The better you work as a team, the better the potential outcome for your patient. That's why it's so important that you understand not just what to do in a resuscitation attempt, but how to communicate and perform as an effective team, regardless of your role as team member or team leader. Welcome to the American Heart Association's Megacode and Team Resuscitation video. In this video, we're going to demonstrate and model an effective resuscitation team in a case scenario. Our simulation will have 6 team members. You may have fewer members depending on the situation, so be prepared to adjust your roles accordingly. Our case study begins in a local emergency department, where a 65-year-old woman has been brought in complaining of epigastric and back discomfort. Hello, I'm Dr. Jackson. What's bothering you today?
Oh, doctor, I don't feel good. I feel really bad. I'm dizzy and I'm sick at my stomach. My son was really worried about me and he brought me in.
Okay, are you having chest pain right now?
No, but I'm hurting. It started in my stomach and now it's in my back.
Okay, we're going to see if we can find out what's going on, okay? Joette, do we have a set of vitals from Ms. Fernandez?
Yeah, blood pressure is 70/40, heart rate is 45 beats per minute, respiratory rate is 16 breaths per minute, and pulse ox is 92%.
Okay, let's go ahead and start her on 2 liters of O2. Ms. Fernandez, we've got you hooked up to a monitor so we can take a look at your heart rhythm, okay? And we've started you on oxygen so you can breathe a little easier.
The pulse ox reading is 95% with 2 liters of O2.
Oh, doctor. Oh, doctor. All right.
Okay, it looks like we have sinus bradycardia. Dana, let's go ahead and get an IV started right now.
Ms. Fernandez, Mrs. Fernandez, can you hear me? Mrs. Fernandez. She's unresponsive. I feel a pulse.
Okay, let's call a code. The patient's gone into VFib. Start chest compressions.
Starting compressions.
Mandel, you'll be on defibrillator. Shelley, you'll be recording.
Recording.
Sam, you'll manage the airway. Dana, have you been able to establish an IV access yet?
I've tried several times, but it's failed.
Okay, let's move on to IO access, please.
Moving to IO access. 4, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Charging at 200 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
I have IO access now.
Great. We'll continue CPR for 2 minutes and evaluate the need for additional defibrillation. Shelley, I'll rely on you to monitor the quality of the chest compressions. Dana, you'll need to draw the drugs up before each rhythm check, so if the arrest persists, we can move quickly to drug therapy. Let's begin with 1 milligram of epinephrine.
Try 1 milligram epinephrine. 2 minutes.
Okay, let's analyze. Switch roles. Okay, the patient remains in VFib. The protocol for this biphasic device is escalated dosing. Let's shock again at 300 joules.
Shocking at 300 joules. Charging. Clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
Continue CPR. Continue compression. Dana, please give 1 milligram of epinephrine.
1 milligram epinephrine. And the IO is flushed.
Great. We've given 2 shocks and given 1 milligram of epinephrine. The next medication to consider is amiodarone. Dana, please prepare 300 milligrams of amiodarone.
Try 300 milligrams of amiodarone.
Sam, are you getting good chest rise? Yes. I'm being careful not to deliver ventilations too quickly or forcefully. Okay, great. Let's continue there.
2 minutes.
Okay, let's analyze. Switch roles. Okay, the patient is in persistent VF. Let's shock again at 360 joules. Charging at 360 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered. Continue CPR.
Continuing CPR. 1, 2, 3, 4. We can give amiodarone now.
Thanks, Shelley. Dana, please give 300 milligrams of amiodarone.
Okay. 300 milligrams of amiodarone given. And the IO is flushed.
We've given 3 shocks. After the second shock, we administered 1 milligram of epinephrine, and we've just given 300 milligrams of amiodarone. Our next drug will be vasopressin. Dana, please prepare 40 units of vasopressin.
Trying 40 units of vasopressin.
Let's review any reversible causes by considering the H's and T's.
What about hypovolemia?
That's a good thought. We have IO access established, but no obvious signs of internal or external bleeding. Anybody else have any other suggestions?
Have we considered hypoxia?
Is the airway still patent?
Still getting the chest ride.
She came in with epigastric discomfort and symptomatic bradycardia. Have we considered coronary thrombosis?
That's a great point. Everything seems to suggest a STEMI.
2 minutes.
Okay, let's analyze, switch roles. Okay, the monitor shows sinus bradycardia. Do we have a pulse?
Feel a pulse.
Continued chest compressions?
Continued chest compressions. 1, 2.
Shelley, how long has it been since our last dose of epinephrine?
3 minutes.
Okay, Dana, let's go ahead and give 40 units of vasopressin.
40 units of vasopressin given. And the IO is flushed. Mandel, your compressions are slowing down. Can you pick up the pace a bit? 2 minutes.
Let's analyze, switch roles. Okay, the monitor shows sinus tachycardia. Sam, do we have a pulse?
I can feel a rapid weak pulse.
Okay, great. Let's initiate immediate post-cardiac arrest care. Dana, let's get a blood pressure, a complete set of vital signs, pulse ox, and labs. Mandel, let's start a 12-lead ECG, please. Can we check to see if this patient is breathing and responsive?
Ma'am, can you squeeze my fingers? She's still unresponsive.
Still not breathing. Okay, let's insert an advanced airway and prepare for therapeutic hypothermia.
The patient's blood pressure is 82/40 with a heart rate of 130 and a rhythm of sinus tachycardia.
Okay, the patient is hypotensive. Let's start with a liter of saline. Since we've started with hypothermia, let's use cold saline for the bolus.
Okay, we'll switch off for cold saline.
Tubes in.
Okay, we've got good breath sounds. Let's establish waveform capnography. The O2 saturation is 96%.
Here's the 12 lead.
Okay, she has a STEMI. Mandel, please call the cath lab and tell them that we have a STEMI patient. PCI and hypothermia can be safely combined after cardiac arrest. The return of spontaneous circulation, or ROSC, is no longer the end of the cardiac arrest protocol. More scientific studies show that survival rates improve significantly with a comprehensive system of post-cardiac arrest care. It is important to know your local system's plan for the management of post-cardiac arrest patients. Hypothermia is the only intervention that has been shown to improve neurologic recovery. The resuscitation team should consider inducing hypothermia for any patient who remains comatose after ROSC. Several studies show improved outcomes for patients whose bodies were cooled to 32 to 34 degrees Celsius for 12 to 24 hours. A new recommendation in the 2010 guidelines is the introduction of a structured team debriefing. Studies show teams who debrief together perform better on subsequent codes. Here's how team debriefing differs from simple feedback. Feedback is geared toward correcting actions. Effective debriefing focuses on correcting the thought process that leads to the action. While debriefing takes longer than simple feedback, it results in deeper understanding. The hallmark of structured debriefing is a learner-centered self-analysis and active participation in discussion. The goal is to gather information on how the code progressed, to analyze the information, to create an accurate record, and to summarize the goals for future improvement. Thanks, team. Nice job. I made a few notes during my evaluation, so let's talk about what went well and why you made the decisions that you made. Well, from my perspective, I thought the code went very well. Shelley did a good job monitoring the quality of chest compressions. Shelley, did we have any prolonged pauses or interruptions in the chest compressions?
No, Joette Mandel both switched positions quickly and resumed compressions, even as the defibrillator was charging.
Mandel, did you get tired or have any trouble with the pace of compressions?
At the end of the code, I was starting to slow down, but Shelley was able to correct the rate of compression, so I was able to pick up the pace. It is easy to lose track of how fast you should be compressing, so having someone pacing you through the code is helpful.
Yeah, maybe we should use a metronome. to help keep pace or make it standard practice to do compression checks at points during the code.
Yeah, that's a good idea. Let's try that next time. Sam, what do you think of managing the arrest without an advanced airway?
We were getting good chest rise the entire time, so we didn't need to interrupt chest compressions to insert an endotracheal fuse.
You know, we could have inserted a supraglottic airway. That could have been done without interrupting the chest compressions.
You know, that could have been an option, especially if ventilation became too difficult. One benefit of using a bag mask ventilation is that ventilations are at regular intervals, and it kept me from ventilating too much. However, because she wasn't intubated, we didn't have end-tidal CO2 readings to monitor CPR quality or detect loss.
Yeah, that's a good observation. It is a trade-off when you consider inserting an advanced airway. Dana, how did you feel about your treatment, especially moving to IO access early in the code?
IO access in adults is new to me, but I found that it was easy to push drugs through.
So, what are the take-home messages?
I thought it was great that we assigned code team roles early in the day, because when the code was called, I knew exactly what I was supposed to do. Yeah, because before we did that, we'd walk into a room and there'd be some confusion.
Good. Anything else? Okay, again, nice job. Successful teams not only have medical expertise and mastery of resuscitation skills, they also practice good communication skills and adhere to the key elements of effective team dynamics. These elements help teams work together in the most efficient way possible. Let's review those now. Closed-loop communication. This is important for both the team leader and team members. When the team leader gives an order, the team member should confirm that he or she heard and understood the order. The team leader should make sure the team member understood the order before assigning additional tasks. Clear messages. Using concise, clear language helps prevent misunderstandings. Speaking in a tone of voice that is loud enough to understand, but also calm and confident, helps keep all team members focused on the task at hand. Clear roles and responsibilities. When everyone knows their job and responsibilities during a code, the team functions smoothly. The team leader should clearly define and delegate tasks according to each team member's area of competence. Know your limitations. Every member on the team should know his or her limitations, and the team leader should be aware of them. Ask for assistance and advice early, not when the situation deteriorates. Knowledge sharing. This is a critical component of effective team performance. Team leaders should ask for good ideas for a differential diagnosis and frequently ask for observations from team members about possible oversights. Constructive intervention. Sometimes the team member or the team leader may correct actions that are incorrect or inappropriate. It's important to be tactful, especially if you have to correct a colleague who is about to make a mistake, whether it's a drug, dosage, or intervention. Summarizing and reevaluation. Summarizing information out loud is a good way to maintain an ongoing record of treatment and acts as a way to reevaluate the patient's status, the interventions performed, and where the team is within the algorithm of care. This technique can also help team members respond to the patient's changing condition. Finally, all team members should display mutual respect and a professional attitude to other team members, regardless of their personal expertise or training. It's important that the team leaders speak in a friendly, controlled voice, avoiding shouting or unnecessary aggression. Not only is it important to know what to do during a megacode event, it's as important to know how to work together as a team during the code. Reviewing how a code went not only helps individual team members perform better in subsequent codes, but may also bring system deficiencies to light. Now we'll play the megacode resuscitation case study again. This time, as you watch, look for the key elements of effective team dynamics. Closed-loop communication, clear messages, clear roles and responsibilities, knowing one's limitations, knowledge sharing, constructive intervention, summarizing and reevaluation, and mutual respect.
The patient's gone into VFib. Start chest compressions.
Starting compressions.
Mandel, you'll be on defibrillator. Shelley, you'll be recording.
Recording?
Sam, you'll manage the airway. Dana, have you been able to establish an IV access yet?
I've tried several times, but it's failed.
Okay, let's move on to IO access, please.
Moving to IO access. 4, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 7, 10.
Charging at 200 joules. Shock ready, clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
I have IO access now.
Great. We'll continue CPR for 2 minutes and evaluate the need for additional defibrillation. Shelley, I'll rely on you to monitor the quality of the chest compressions. Dana, you'll need to draw the drugs up before each rhythm check, so if the arrest persists, we can move quickly to drug therapy. Let's begin with 1 milligram of epinephrine.
Try 1 milligram epinephrine. 2 minutes.
Okay, let's analyze. Switch roles. Okay, the patient remains in VFib. The protocol for this biphasic device is escalated dosing. Let's shock again at 300 joules.
Shocking at 300 joules. Charging. Clear the patient. Shocking on 3. 1, 2, 3. Shocking. Shock delivered.
Continue CPR.
Continuing compressions. 1, 2.
Dana, please give 1 milligram of epinephrine.
1 milligram epinephrine. And the IO is flushed.
Great. We've given 2 shocks and given 1 milligram of epinephrine. The next medication to consider is amiodarone. Dana, please prepare 300 milligrams of amiodarone.
Trying 300 milligrams of amiodarone.
Sam, are you getting good chest rise?
Yes, and I'm being careful not to deliver ventilations too quickly or forcefully.
Okay, great. Let's continue there.
2 minutes.
Okay, let's analyze. Switch roles. Let's review any reversible causes by considering the H's and T's.
What about hypovolemia?
That's a good thought. We have IO access established, but no obvious signs of internal or external bleeding. Anybody else have any other suggestions?
Have we considered hypoxia?
Is the airway still patent?
Still getting the chest right.
She came in with epigastric discomfort and symptomatic bradycardia. Have we considered coronary thrombosis?
That's a great point. Everything seems to suggest a STEMI.
2 minutes.
Okay, let's analyze. Switch roles. Okay, the monitor shows sinus bradycardia. Do we have a pulse?
I don't feel a pulse.
Continue chest compressions.
Continuing chest compressions. 1, 2, 3.
Shelley, how long has it been since our last dose of epinephrine?
3 minutes.
Okay. Dana, let's go ahead and give 40 units of vasopressin.
40 units of vasopressin given. And the IO is flushed. Mandel, your compressions are slowing down. Can you pick up the pace a bit? 2 minutes.
Let's analyze. Switch roles. Okay, the monitor shows sinus tachycardia. Sam, do we have a pulse?
Feel a rapid weak pulse.
Okay, great. Let's initiate immediate post-cardiac arrest care. Dana, let's get a blood pressure, a complete set of vital signs, pulse ox, and labs. Mandel, let's start a 12-lead ECG, please. Can we check to see if this patient is breathing and responsive?
Ma'am, can you squeeze my fingers? She's still unresponsive.
Still not breathing. Okay, let's insert an advanced airway and prepare for therapeutic hypothermia.
The patient's blood pressure is 82/40 with a heart rate of 130 and a rhythm of sinus tachycardia.
Okay, the patient is hypotensive. Let's start with a liter of saline. Since we've started with hypothermia, let's use cold saline for the bolus.
Okay, we'll switch out for cold saline.
Tubes in.
Okay, we've got good breath sounds. Let's establish waveform capnography. The O2 saturation is 96%.
Here's a 12-lead.
Okay, she has a STEMI. Mandel, please call the cath lab and tell them that we have a STEMI patient. PCI and hypothermia can be safely combined after cardiac arrest.
In this section of the course, we've shown you the key steps involved in the adult cardiac arrest algorithm, as well as the post-cardiac care algorithm. to promote a positive patient outcome in the event of the return of spontaneous circulation. You've also evaluated the megacode scenario with the key elements of effective team dynamics and structured team debriefing. Combining your knowledge of essential arrest skills with effective team dynamics can give your team a better chance of success with every resuscitation attempt.
Okay, questions? Hi guys. Any questions? Nawala na sila. May questions po ba tayo regarding dun sa algorithms and megacode natin?
How about, sir, yung you have to leave the extremity where you injected the medicine after giving it?
I'm sorry, Doc?
How about yung, di ba before kasi in our previous ACLS training, we need to lift up the extremity with IV where we injected the medicine or the epinephrine or whatever.
That is primarily for the adenosine administration, Doc. No? Okay, in the epinephrine, okay, or atropine, okay, or other medication, okay, it is not in the guidelines, okay, or it's not recommended in the guidelines unless, okay, we are giving an adenosine, okay, to facilitate the gravity principle for the circulation. Okay, kasi when we are in a cardiac arrest, of course we do not have a circulation. Okay, so the raising of the arm, okay, during the cardiac arrest is not anymore, or it is not recommended kasi there is no or it doesn't help, okay, the circulation. Okay, what we have to focus on, okay, is the compression, okay, in cardiac arrest. Okay, so no need, okay, to raise the arm, okay, in cardiac or during the cardiac arrest. Okay, just the flushing, no? Okay, the emphasis is on the flushing, okay, para at least, no, okay, the medication will not be stuck, no, okay, or the some of the medications will not stuck on the distal part, okay, of the IV tubing.
Okay, thank you, sir.
Thank you, Doc. Any more po? The induced hypothermia or the hypothermia management here in the Philippines are not being fully introduced, no? Okay. In other countries, meron pa silang hypothermia bed, okay, or blanket, no? Okay, where there is an electronic bed, okay, or blanket na pag sinaksak natin sa kuryente, okay, there is an increase or a decrease, no, okay, in temperature, okay, of that bed, okay, to suffice the decrease of the temperature of the body, especially the extremities. Okay, yung ang sinabi lang kanina kasi sa video, okay, is the administration of a cold saline, okay, to initiate the drop, okay, of the blood or the core temperature to 32 to 34. Okay, pero in other countries meron pa silang mga ganun na hypothermia blanket. Alright, hindi nga masyadong ginagawa, no, here in the Philippines, no, yung induced hypothermia. Okay, anyway, may iba po bang question before our first break na kasi 9 a.m. Question po? Question? Wala na. Tahimik sila. Okay, let's have a 10-minute break, okay? Our first break now this morning, okay? Then we will discuss the 12-lead ECG, okay, in relation to the acute coronary syndrome, okay? My time is 9:01, okay? We will resume at 9:11.